oral tradition, and in our way of life, our storytelling is so important, and being able to remember our stories. And the written word is something that we all partake in today, but just a couple of generations ago, our existence, our worldview, everything was carried through our stories. And so our memories are critically important. As I'm thinking about the last 50 years as we prepare to celebrate National Indian Health Board. By the way, if you would like to come to our conference, it's the 26th to the 28th. And we plan to have a really, really good time. But I think about 50 years ago, what life expectancy was. That was one of the statistics that the Indian Health Service used, and why they were, or the federal government used, and why they created the Indian Health Service, with a focused attention on health issues, public health, that affect our life expectancy. We have closed the gap over the last several decades of life expectancy, where at one point we were around 42 years was life expectancy. Now, of course, those, we know in our traditions, we have people that lived much, much older than that, but the impact of intervention, of relocation, reservation, all of those commodities, all those things kind of lowered the life expectancy. So now we're facing a new challenge as we are living longer, and now we're noticing some of these environmental conditions or outcomes where we're suffering from Alzheimer's and different challenges with dementia to our brain recollection. So I can't say enough how important our oral traditions were in being able to know who we are, remember who we are, our language. And so one of the threats to that, of course, is not having full access to those memories, and the challenges that Alzheimer's and dementia might represent for our people. Also, like I said at the beginning, I'm not an expert in brain health, but I know the appropriate place for our elders in our society. And so, you've heard the 7 grandfather or grandmother teachings, and I like to say 7 grand teachings. And 3 of those are wisdom, knowledge, and respect. And so our elders are key. They hold the key to our past because they have the longest lived experience. And over time, when you're young, you think you know it all. And I was one of those young know-it-alls at one time. But as time goes on, you have a context for understanding, and you're understanding things much better. So as elders, we are dependent on our elders to be that source and that reservoir of knowledge. In our traditions, they had that respectful place where we would look to them for guidance and direction. And so all the more important that they have access, and that we have healthy brains, and that we look to try to address what we believe might be a higher incidence of Alzheimer's in our community. But I will also say immediately that there's much more information that we need. There's greater data collection that we need, and that's not unique to the issues of Alzheimer's. Just overall, federal public policy for data collection and understanding our Native communities is a challenge. Those who know, especially through the pandemic, a lot of the data surrounds the purchase and referred service area and our health delivery service area. And we have really kind of little information about our people that live away from our reservation base or our service areas. I think about some of the challenges that the pandemic represented for our elders. And I believe I saw Cynthia LeCount, who was scheduled to be on with us. I didn't check to see. I didn't have my glasses on during the prayer, so I couldn't check. But during the pandemic, in order to save those lives of our critically important elders, we made the tough choice of shutting down our congregate meal programs, and we're only now beginning to reopen and have access. I suspect that very valuable socializing opportunity for our elders to meet with other elders, to share stories, just the camaraderie, and if nothing else, just the exercise of our meeting with other people and making contact with other people was interrupted during the pandemic. And however, and at the beginning of the pandemic, when we started pushing out connecting elders through social media, I can tell you before the pandemic, I had never connected on social media or never connected through Zoom. I didn't even know what that was. I thought it was kind of strange, actually. But over the experience, we see elders are connecting that way. And so I don't want to go backwards. I think that helps to stimulate our elders socializing and their cognition. And I think that's healthy for us. And so hopefully some of what we learned won't be lost. I also think that we probably missed some critical points of intervention for elders as they began to lose maybe some of their memories. And so we need to be thinking about how do we get caught up as we come out of the pandemic. So, also there's clearly a need for us to focus some attention on diagnoses and adaptive cultural screening of tribal communities so we can see if we can detect beginning onsets of dementia or Alzheimer's in our respective communities. So, I think at the end, we will talk a little bit more about some observations and maybe some more focused attention. And so with that, I'll leave that and I'll listen and hopefully try to pull out and extract some of what we hear today. So I'm glad to be here to emphasize the importance of our elders and also the importance of good brain health. And so with that, I'll hand it back to Carrie.
Thank you. Thank you, Dr. Payment, for those words, and thank you, Carla, for the blessing. So before we get started into the presentations, I just want to give a little, well, first I want to recognize our funder and co-host, the Alzheimer's Association. Shelby Roberts is the director of the Healthy Brain Initiative with the Alzheimer's Association. Shelby, do you want to introduce anyone on your team?
Hey, thanks, Carrie. We're so happy to be here today and to be able to support this work and hear from you all. Also on the line, we have our whole team, but I'll just introduce to you all Eva Jackson. She's a new member of our team who's an associate director and excuse me, is leading the implementation of the roadmap for Indian country. So she just started with us about a month ago, so she'll be a new name that will hopefully become a familiar one. And I'm excited for you all to be able to see her face there on the screen today, and then you'll be hearing more from her in the coming months. But thank you all. We're looking forward to hearing from you all today.
Thanks, Shelby. I also need to talk about a disclaimer because the meeting is being recorded. If you do not consent to being recorded, you're asked to drop off the meeting at this time. All right, thank you. Let's get started. I want to share some brief information about the mini grants that that NIHB has offered. First of all, it's estimated about 3 in 9 American Indian Alaska Native people over 65 will develop dementia, compared to 1 in 9 of the overall population in the United States. Alzheimer's disease and related dementias are marked by persistent difficulties with memory, thinking, and completing everyday actions like preparing food or sharing stories with loved ones. We know that ADRD heightens the need for healthcare services and caregiving for elders. The National Indian Health Board was definitely interested in helping raise awareness about this issue, and we were fortunate to partner with the Alzheimer's Association to be able to offer mini grants. So we launched a mini grant program last fall. We are providing 4 tribes, just a very small amount of funding, just $15,000 each. They all chose a tribal partner to work with and also chose strategies from the roadmap for Indian country to work towards. And we'll hear more about the roadmap. So I want to get started, and let me share my screen and get the presentation going. Okay, are you seeing my screen?
Yes, we can see
Great.
it.
So this is just the overview agenda. We had the opening. We will hear from 4 of the tribal presenters. Hopefully, if we have time, we'll do Q&A. I have a few resources to share, and then Dr. Payment will close and wrap it up for us. The National Indian Health Board, if you're not familiar with this organization, they was established by the tribes to advocate as the united voice of federally recognized American Indian and Alaska Native tribes. NIHB seeks to reinforce tribal sovereignty, strengthen tribal health systems, secure resources, and build capacity to achieve the highest level of health and well-being for our people. NIHB is a 501c3 organization created by the tribes 50 years ago. It's the 50th anniversary, located in Washington, D.C., and serving all federally recognized tribes. Just wanted to share that if you weren't familiar with the National Indian Health Board. So let's start with Mount Sanford Tribal Consortium with Jody Hatch. I'll read Jody's bio, then I'll turn it over to her. Jody Hatch lives in the Athabascan village of Christachina, where she has worked for Mount Sanford Tribal Consortium for 8 years as a community health practitioner, and the last 3 as the deputy health director. She enjoys providing direct patient care to her community or as an EMT. In her free time, Jody enjoys gardening, raising chickens, and spending time with the family. She loves picking berries, fishing, processing the harvest. She is currently pursuing her bachelor's degree in business administration with a health administration concentration, and her future goals include attending school to become a physician's assistant. Welcome, Jody, and I will turn that over to you.
Thank you. I was warned not to read this because it's kind of wordy. So we are a very small tribal health organization, and we previously, until last year, I had provided services for 2 villages. We are down to 1 village, and we have, as I said, a very small population, but I am part of the team that provides direct healthcare. So I have a very intimate connection to my community, and this grant was an opportunity to increase our services. I appreciate it very much. So thank you for that. We are on the road system, and this matters in Alaska, but we are quite far away. So functionally, we are the same distance as a medevac to one of the more remote fly-in villages. So while our village has about 100 full-time residents, and no, we don't count the dogs anymore, but we do have surrounding areas that we see those patients as well. So as I said, we're spread out, but it's a very small community. Alaska is best described as a very spread out small town. We know everybody and everyone knows us. Next slide. So our elders are very definitely our center. They come to all activities if able. We do everything to support them to stay in their home. They need to be where they live. They need that connection to the land. Going to town for medical services is hard on them, and we try to make that as easy as possible. Having said that, our population is definitely aging. Our median age now is about 45, might be a little older, but so we wanted to be able to look at how we could support early interventions, finding ways to support people staying in their village, being more proactive, and timely interventions. Just makes sense that would help more the sooner we know that there's a problem, or the sooner we can say, no, this is different. This isn't what you're thinking it is, because it goes both ways. Family are so close that it can be scary when something changes, and we need to be able to either reassure them that this is a normal change or that this is something we can do something about and support them with that. And, you know, this is our mountain. This is Mount Sanford. Next slide. So one of our resources that we have here, we have community health aid and practitioners. So I am a community health aid practitioner. I am trained in the IHS system. I only exist in Alaska. We're working on expanding to the lower 48, I believe, but I don't know where that is currently. I will say if you have the option to look into that, absolutely do that, because we have more ability to connect with our patients. Providers have a very short window of time to get in, get out, try to figure out what's going on and provide services. So we are able to sit, we are able to talk to the elders, let them get into a space where they feel better able to tell us what's going on, and just be patient, because it does take a little bit longer. So another benefit is that I see my patients. I see them mostly daily. And so sometimes I'll notice something that isn't, maybe it's not said, but I've noticed, you know, maybe they're moving differently, or if they're having trouble and somebody brings it to my attention, and I can then go and do a home visit and check on that elder. And it's a comfortable thing. I'm not invading their space. I can actually connect with them there where they're more comfortable to speak with me. So our Chishna Village Council president is one of our champions. She is also our dental health aid therapist, which is another arm of the community health aid program. And she is also a tribal judge. I mean, we wear many hats in small villages. So this is roughly on that map. It doesn't specify, but we are considered South Central Alaska. So we have, we're not quite as far north as some. Next slide. So we chose training clinic staff, and then we also trained our admin staff. So we have 3 health aides, 2 full-time and 1 on call. And we are lucky to have them be consistent. We've had them throughout. We did not lose any staff during the pandemic on the clinic side, which is a miracle. And it worked out quite well. We also shut down most activities. And so it was a challenge trying to keep our elders connected. But training administrative staff, for us, that means we have grant activities that we're doing not only for the clinic, but on the other side. So there's SAMHSA grants. And in all of those, we've trained everybody, not so much for medical interventions, but obviously we just ask that if they notice something, maybe they can bring it to our attention so that we can then check in with people and check in with the families, see if there's something that we can do to help them. Next slide. So community health aides use the community health aid manual. It is our entire scope of practice. We are able to have additional standing orders, and sometimes those, depending on what the training is, that will give us more tools. So now these are health aides in villages, and it's just kind of some background. Carrie had asked me to talk about it a little bit in case somebody wasn't familiar. There are screening questions in our intake process that we ask just as a matter of course, and we may or may not ask them for elders, but we do ask not only about how they're feeling, but are they doing okay? Do they have enough wood? Do they have enough water? Are they able to get, what do they need? We have a water system here. I think everyone has running water, and but we do have a lot of people who use wood. And so we like to make sure we supply wood for elders. We supply garbage service so that they don't have to worry about that. And then we do annual safety surveys for their homes, make sure there are no fall hazards. These are all things that are included in our CHAM. And so there's information for CHAPS, changes of aging, what are normal changes, what are more concerning. And so we use all of those, and then we kind of rearranged our own intake process to add some questions that we wanted to know more often. We don't ask them every visit, but we do check in with our elders. And this has definitely informed how we're seeing them now. Next slide. So like I said, frequent home visits for elders. And then because we're in their home and they like to visit, we have the ability, and our leadership is encouraging it, that when we go to visit, we can take as much time as we need. And we're not catching them, we're not just seeing them when they're acutely ill, we are seeing them when they're at home, when they're making tea or they're walking in the yard. So it gives us a better perspective, and we're lucky to be able to spend time with them. They enjoy it, and so do we. Next slide. This is your gratuitous moose photo. Raising awareness and educating the community. We are ongoing with this, and we will continue our clinic staff trainings, and just so much right now is more practice. Like, we want it to be conversational. It's not an interrogation. We just want to make sure that we're getting the best picture of what they need from us. And families, sometimes it's better for us to meet with families with the patient, and sometimes it's better separately. So it just depends on the situation. Next slide. So the Zoom meetings work for us to a point. They work for the family more than they work for our elders. They laugh and they like the iPads, but they have trouble hearing over them. And so it's easier for us to just get them together, and then we can have a better idea. And we're working on that. We've made progress in setting up some meetings. So the elder who can't hear me when I'm asking questions can absolutely hear her sister, even though she speaks softer than I do. So it's really nice to see them connecting and spending time together. Next slide. That's it. Okay, so we're going to continue to use our health aides, us. This is something that we're excited about, and we're working on, and it's been great for us to just kind of focus on this. It hasn't been a hardship. It's sustainable. It's something we can do easily. This is just an example of, this is the plan in the CHAM. So if somebody comes in and says, I think my mom is having trouble with her memory, then you'd look at these. And these are all these drop-down menus. I'm sorry, I couldn't make them so that we could open them, but the mini cog assessment, health and habits, all of these things give us the bigger, more fuller picture of where that elder is. In pretty much all aspects. And then we can follow up with our referral doctor, and we can talk to specialists at ANMC and ANTHC. There's an elder program. We can get them resources. We can connect them to the Alzheimer's if that becomes necessary. So we want to continue. A main goal of us in the community is to keep them involved in our social activities and community events. Our pandemic, of course, has just been so much fun. So, but we've actually done testing so people can go visit, and that we can have something for them to do, because isolation is not good for anyone's health or social well-being. So, next slide. This is the last one. I am happy to give anybody information if it's possible. Photography credit goes to Stacy Charlie. These are her photos, and we recently lost her. So thank you, everyone.
Thank you, Jody, and sorry to hear that. They're lovely pictures.
She's quite talented.
Well, thank you. If there's questions, you can put them in the chat, or we'll hopefully have time for a Q&A. But let's have go through all the presentations first until we do that. So next, I want to introduce Tawny Booth. She's the grants manager for Chicagoan Chippewa community. Chicagoan Chippewa community. Let's see. Tawny currently serves as the Chippewa Community Health Clinic's grants manager. She's worked with the clinic since 2019 when she joined the position in Medicaid eligibility outreach specialist. She has an established career in health clinic administration with over 30 years of experience serving in roles as a health service specialist, human resources director, fiscal director, and health information management specialist for several tribes and organizations. Welcome, Tawny, and she may be having trouble with her camera. So we'll just I'll turn it over to you, Tawny, for voice only. You can go ahead and unmute. There you go.
I work for the Chicagoan Chippewa community. We're located on the Mole Lake Reservation in Crandon, Wisconsin, which is located in Forest County. We have approximately 1,377 tribal members, 1/3 of whom live on the reservation, while the rest live off the reservation, but often nearby. The Chicagoan Chippewa Community Health Center provides primary and urgent care services, including dental, chiropractic, massage therapy, behavioral health services, including mental health and substance use disorders. We started out with approximately 1,700 registered patients, averaging 3,500 patient contacts per year. Since the onset of COVID-19 pandemic, the tribe declared a state of emergency in March of 2019. And then we started our drive-through COVID-19 testing in April 20th of 2019. We became one of 3 testing sites in more than a 30-mile radius. And as of today's date, we've tested over 16,000 people, of which about 800 were positive. So our tribe closed down the casino, and the whole reservation was closed down, except for the C-store, our convenience store, was on a limited basis, and the clinic, the front doors were locked, and only patients that get tested for COVID could enter the building. So that's when our testing, patients went up significantly, and we're probably seeing 6,000 encounters per year. The patient base is composed primarily of SSD tribal members and employees, but the clinic also serves non-member residents in the rural surrounding Langlade, Oneida, and Forest counties. And those populations with those surrounding counties combine 256,930, according to the 2018 estimates. And then all these counties are defined as rural in the Rural Health Grants Eligibility Analyzer. And then the clinic expects to continue to be the main provider of COVID-19 testing. And we also are very high with our vaccination efforts for our members and their community members in the area. Next slide, please. The Chicagoan Chippewa Health Clinic reported only one diagnosis for dementia and Alzheimer's due to the lack of resources within the community in the last 3 years. And the SDC, which is Chicagoan Chippewa Community Elderly Department, only reported 10 of their elders that participated in the Music and Memories program from 2014 to 2018, which consisted of iPod and notebooks to track their progress. Based on the results of the tracking, it was determined who should have screening done. However, the roadblock was getting elders to be seen at our memory clinic in Rhinelander, Wisconsin, along with the cultural beliefs and due to the stigma of them being diagnosed with dementia or Alzheimer's. The SCHC wants to focus on early detection and diagnosis. Next slide, please. So our starting point was that our strategies included the SCHC Health Clinic wanted to accomplish and educate to empower the tribal community members on the importance of early detection and treatment. We wanted to work with tribal community members to understand that brain health, early warning signs of dementia, and the benefits of early detection and diagnosis for persons with dementia and their caregivers and the number. We wanted to provide that information and tools to help older adults with the dementia and their caregivers to anticipate and respond to challenges that typically arise during the course of dementia. Outreach efforts will be critical in accomplishing these strategies and working with the elderly department on hosting events related to the growing problems of dementia and the heavy impact on families and communities. Also, by reducing stigma, we can support dialogue within a community about how to promote wellness across the lifespan and best support of older adults with dementia and their families and their caregivers. Next slide, please. What worked well, sorry. We held 2 outreach events, which included a health fair on May 12th, 2022. And then we, the tribe hired a new elderly director. So we held a meet and greet with the new elderly director with our behavioral health department and the medical providers and the grant staff on June 2nd, 2022. With the outreach and event materials, our targeted goal was to reach out to 20 elders. At the health fair, we gave out materials, brochures, and books that related to dementia to 25 SCC tribal members. We do screening with providers to incorporate into their exams. We received 2 mini mental state exams from the providers that they completed on the SCC tribal elders, and referrals were made to the memory clinic in Rhinelander on the results of those mini exams. We developed a brochure and mailings to community members. The brochure has been developed and in process of mailing out to the tribal community. Resource training for family and caregivers, educational resource books for the caregiver, guides for dementia, caring for a person with memory loss and confusion were handed out to elderly caregivers and families, which are included on the slide. Next slide, please. In addition, we ordered additional resource books that we will be handing out to our tribal community on how to care for the aging patients, who will take care of me when I'm old, the complete elder care planner. And for the elders who ordered, we ordered fun and relaxing activities for adults, the fun and relaxing adult activity book, and then the simple coloring book for seniors, which are all included on the slides. Next slide, please. What didn't work as expected? The medical director, we wanted to host events and speak with our elders. However, due to the COVID-19, we were unable to see elders in their building per tribal council direction. They kept the elderly protected by locking down the facility and not allowing community members or any other employees to come into the building unless for cleaning and taking care of the elders. We wanted to work with tribal law enforcement and training on signs and symptoms of dementia to assist with potential wanderers within the community and silver alert if they go missing. We're unable to do this activity due to the vacancy of law enforcement officer. Challenges, we're definitely dealing with COVID-19 pandemic with multiple closures on the tribal reservation, with quarantine protocols that were implemented with the tribe's ICS team and council. Another challenge we also encountered was a vacancy of the elderly director position that is still vacant today. Hopefully, you know, we have a new HR department as well. So we're promoting, trying to find these positions and get them filled. Next slide, please. In hindsight, obviously, if we were not dealing with the COVID-19 pandemic, the vacancy of our law enforcement and the elderly director position and ADRD stigma, the project would have worked perfectly. And we will continue on with this progress in the future and try to find some other funding if possible. Next slide, please. So like I said, we hope to find additional funding to support the ADRD in the future. We feel that the early detection of dementia is important. We'll continue to do our many mental state examinations and refer to the memory clinic if needed. Next slide, please. And if anybody has any questions or would like any ideas on materials that we did for outreach, contact me, Tony Blewett, the grants manager, by email or by phone is my direct line. And I would like to thank for the funding opportunities that we were able to try to accomplish some awareness out in our community.
Thanks, Tawny. Thanks for your presentation. You had a lot of obstacles and roadblocks with a lot of staffing. And we know that it's somewhat common in Indian country to have vacant positions and how important just one person in a position can be. So I think you all did great with what you had to work with. And I look forward to seeing what you'll do in the future. I think you've built a lot of good relationships in your community, and they know who the people to go to are now. So next, I want to introduce Charlene Nolte of the Aleut community of St. Paul Island. Drawing on over a decade of expertise, Charlene Nolte specializes in public health and child welfare services. Prior to embarking on her professional journey, she received a bachelor's degree in sociology and criminal justice from South Dakota State University in 2003 and a master's of science in psychology with an emphasis on terrorism and security from Walden University in 2010. Nolte focuses on community-based programs ranging from emergency management and disaster preparedness, hazard mitigation, and climate adaptation to behavioral health, child protection, domestic violence, sexual assault services, and general welfare assistance. Sorry. Welcome, Charlene. And I can't remember if you were having trouble with your camera as well. We know broadband in Indian country has a long way to go, and this is so just it's okay if you want to just do voice.
All right, thank you, Carrie. Thanks everybody for attending this morning. As you can see on my slide deck here, I have a picture of Alaska with a little arrow pointing to a little blip in the middle of the Bering Sea. Islands are about 42.6 square miles of land, or 800 miles west of Anchorage and 300 300 miles north of the Aleutian chain. That's about a 3-hour plane ride for those of you who are interested in how we get to and from St. Paul Island. We have a population of about 475 people. 83.96% are of Anunga descent. We currently have about 58 seniors we serve here in St. Paul. 19.95% of the population actually speak Anunga Tinu, which is the official language of the Aleut people of St. Paul. And we have lots of other facts that help the identity of St. Paul. You'll hear a little bit about that in my next couple of slides. Can you go to the next? This is actually what St. Paul Island looks like. If you look down to the bottom of the screen, there's a little black dot. That's where the actual village, the site of St. Paul is located. St. Paul is located on the narrow peninsula on the southern tip of St. Paul Island. It's the largest of the 5 primitives. Next slide. So the Pribilofs were discovered in 1786 by Russian fur traders. They landed first on St. George and named the larger of the 2 islands St. Peter and Paul. In 1788, the Russian-American company enslaved and relocated the Aleuts from Siberia, Africa, and Alaska to the Pribilof Islands to hunt for fur seals. Descendants live on the 2 islands today. In 1780, the Alaska Commercial Company was awarded a 20-year sealing lease by the U.S. government, and it provided housing, food, and medical care to the Aleuts in exchange for seal harvesting. In 1890, a second 20-year lease was awarded to the Northern American Commercial Company. However, the fur seals had been severely overharvested and poverty ensued. In 1910, the Fur Seal Act ended the private leasing on the island and placed the community and fur seals under the U.S. Bureau of Fisheries. The food and clothing were scarce, social and racial segregation were practiced, and working conditions were poor. During World War II, the Pribilof Aleuts were moved to Frontenac Bay on Amarillo Island in southeast Alaska as part of the emergency evacuation of the residents from the Bering Sea. Unlike other Aleutian residents, they were confined in an abandoned cannery and minery camp at Frontenac Bay. In 1979, the Aleut Islanders received $8.5 million partial compensation for unfair and unjust treatment and were subject under federal administration between 1870 and 1946. In 1983, Congress passed the Fur Seal Act amendments, which ended government control of the commercial seal harvest and the federal presence on the island. Responsibility for providing for community services and management of the fur seals was left to the local entities. $12 million was provided to St. Paul for help to develop and diversify the local economy. Harvesting ended on St. Paul Island in 1985. So until 1985, the residents of St. Paul were enslaved to the federal government or wards of the state, if you will. There was a lot of unhealthy practices in the canneries. The people of the islands were removed and they weren't provided access to their subsistence foods and basically were left starving and hungry there in Frontenac Bay. When they returned to St. Paul, their island was devastated, their homes were ransacked. And it took a lot of years for them to be able to start hunting seal here in the Pribilofs again. Do you want to move to the next slide, Carrie? So this brings us to why we are addressing Alzheimer's disease and related dementia. We noticed over the years, we had an increase in our elder population who was being diagnosed with dementia or showing signs of early dementia. So we needed to be able to address that here, and we had to do a lot of work in order to figure out how to even go about getting diagnoses. At some point, people thought it was behavioral health's job to get people seen and diagnosed. The behavioral health people thought it was the job of the medical clinic to do that. And we just realized over time that we needed to do some work to bring our practices together. So here in St. Paul, we our medical services are provided by South Central Foundation through ANTHC, and the tribe provides the clinical or the community-based services. Even though we're in the same building, due to HIPAA and confidentiality practices, we weren't talking, we weren't communicating. So we asked for this grant to help increase that communication so that we could address these needs. Now we're able to meet to clarify our referral processes and services. We needed to educate our community on the warning signs, diagnosis, and treatment. And then we needed to find a way to address the contributing factors such as untreated depression, obstruction in sleep, and vitamin B12 deficiency. So over the course of the last 10 years, we've seen a significant increase in diagnosis and elders needing to relocate to other areas where services can be directly provided to them, as we were lacking those services here locally. Next slide. So for the purposes of this mini grant, we chose to complete 2 strategies to maximize the benefits here in the community, which was educate, empower, and strengthen our workforce. To educate and empower, we work with South Central Foundation to create flyers and local resources to St. Paul Island and tribal members. We created an Aging Well trail map. We created a preventing and delaying cognitive decline flyer, memory loss and dementia tools to prepare caregivers for potential early detection and diagnosis of dementia. We work with community members to understand brain health, early warning signs of dementia, and benefits of early detection and diagnoses for persons with dementia and their caregivers. Under the strengthen the workforce, we educated our local health center staff, both tribal and South Central staff, on aging services, about the signs and symptoms of dementia, and caregivers for persons with dementia by having them attend various trainings, including the Brain Health Action Institute and Tribal Nations module. We did a lot of work with South Central Foundation, going over what services were available in Anchorage or other parts of Alaska, and what services were available locally in St. Paul, and how we could combine the two, see if there were any services that we had going in Anchorage that could be moved to St. Paul, and how we would go about doing that. Next slide. So in order to do that, we needed to understand who the people on the team would be to start developing those services. So we identified people who could be held to task. So who owns the task? Do they have the authority to be held accountable for the task? Do we agree that they're set up for success with time, resources, and clarity? And do we have a checklist of what needs to happen to accomplish the task? So once we were able to answer all of these questions and select all of the team members, we were really able to get out into the community and talk to caregivers and family members of those who were either waiting on a dementia diagnosis or those who had already been diagnosed with dementia, and those who had family members who had to relocate from our community to other communities so that services could be provided for them. So we focused on some working groups to make sure that we found what all of those caregivers and families needed in order to be successful to help their family members, and what services they felt could be offered locally that we weren't providing. We created and identified resources that we could provide here. On top of that, we needed to find out who in the community could be tasked with various parts of the work. So identifying staff at South Central Foundation and staff within the tribal government who could go out and do things such as home visiting, preparing healthy elder meals, and those kinds of things. Next slide. So as we started to work through the project, we decided that we needed to meet fairly regularly. So we decided that we would meet every 2 weeks to make sure we were, number one, meeting the grant objectives, but 2, just meeting the needs of what we needed to do in the community. In order to get information out, we decided that we would create flyers and informational brochures that would be presented at our community health fairs. We typically have 4 health fairs a year in St. Paul, but due to COVID, we were only able to actually host 3 of the 4 that we had. We decided that we would introduce brain healthy foods into our elders meal program. And we also developed a weekly food demonstration course. So we know that foods that you eat play a role in keeping your brain healthy and improve specific mental tasks such as memory and concentration. In our elders meal program, we focus on ensuring we have local foods that support brain health, such as berries, eggs, broccoli, dark chocolate, nuts, green tea, and fish. Salmon and other fish such as rich source of omega-3 fatty acids. Omega-3s offer several additional benefits for your brain. For one thing, they may slow age-related mental decline and help ward off Alzheimer's disease. On the flip side, not getting enough omega-3s is linked to learning impairments as well as depression. So we made sure that in our elders meal, in our nutritional outreach, that we provided salmon and other fish with omega-3s. We also made sure that we had enough coffee for our elders. Coffee has 2 main components, caffeine and antioxidants, that can support brain health. The caffeine found in coffee has a number of positive effects on the brain, including increased alertness, which keeps your brain alert by blocking anosine and chemical messenger that makes you feel sleepy, improved mood, and sharpened concentration. We know that we can use food here in St. Paul to support brain health and boost alertness, memory, and mood by strategically including these foods in our diet. Another area we focused on during this mini grant was staff training. Staff attended many trainings, but we wanted to highlight the Brain Health Action Institute for Tribal Nations modules, advanced care planning courses, palliative care leadership. And with South Central and those trainings, we were able to create comfort pack manual, family meeting, and end of life education materials for our families and caregivers. Next slide. So during this award, we were able to strengthen the relationship between our agencies, making sure that whenever we had somebody who was presenting with signs of dementia, that we contacted the right members of the team with the medical providers and the community-based providers. We created care plans for the families, and caregivers were able to provide home visiting support services. We were able to deliver like healthy meals to the houses and just provide those in-home services that we weren't able to provide before. We were able to meet directly with the experts from South Central Foundation who were delivering this service versus just talking to the administration staff, such as the receptionists or the people who didn't really know how to help us. And we were able to look at other options available in Alaska as well, and what services they provided and how helpful they were. Next slide. See, these are some of the products that we were able to develop, and we were able to use these to make them St. Paul specific. So we were able to create the guide to family meetings, an aging well flyer on memory loss and dementia, an aging well flyer on advanced dementia, and like I said, the roadmap of looking ahead. We're able to get these products out in the community, do a yearly newsletter, and we were able to put all of these flyers into our newsletter that went out in the community. Next slide. What did not work well? Today I'm on this call without video because we have huge bandwidth issues, and right now due to COVID protocols, we're not able to get our local systems providers out here in the community to fix our landlines, and oftentimes our cell phones don't work. So just direct communication with technology has been an issue. Competing priorities. St. Paul is very small, our workforce is very small, and a lot of us during COVID were tasked with COVID response and all of the activities that went with that. So we had lots and lots of competing priorities. And unfortunately for us, we had three of our staff members that provide elder care had to go out on maternity leave. So while we love children, it kind of put us back a little bit. Next slide. In hindsight, working on this award, we realized that we needed to actually add some elders and some caregivers to our development team. While we did focus groups, I don't think their voices were as actively heard as they could have been if we would have had them on the development team. We have to agree to continue to meet even after the award ends, to continue to meet the needs of the community members and families who are providing care to their elders with dementia. We need to continue to develop a process to share the information across the agencies. We realize that there are other players, ANTHC, who was not directly at the table with us, who provide a lot of the services coming in and out of St. Paul. So having them at the table probably would have helped us a little bit more. And actually invite caregivers to the trainings that we sent our staff to. They were very informative. Our staff learned a lot, but I wish we would have been out to the community or invited the caregivers and families to participate in those trainings. Next slide. What we still have to do is we have been working on a video to disseminate information on the warning signs of dementia and what foods are locally sourced that support brain health, and just different services that we can provide here locally. We definitely intend to train more caregivers with the trainings that I talked about earlier in this meeting, and actually having more of our healthcare providers coming out to St. Paul to provide actual hands-on training on how to do some self-services with our caregivers and families, and continue education as we learn more and more trained on how to make those early detections. Next slide. This is my contact information. April Cushion was the director for South Central Foundation. She's left South Central Foundation to come work for the tribe as our healing and wellness director. So I feel like that was a win for us, a loss for South Central. Heather Goki is the clinical administrator for South Central Foundation, and there's her contact information.
Thank you, Charlene. Thank you for sharing all that information. and especially the partnership. It sounds like you really made a strong partnership or stronger partnership with South Central Foundation. And you stole one of their employees. How'd you do that? No, just kidding. That's awesome though, that you're getting more staff. So,
Yes.
so we're gonna move on to the last presentation, and that will be Cheyenne and Arapahoe Tribes Department of Health. Daryl Cox will be the presenter for that. Dr. Cox joined the Cheyenne and Arapahoe Tribes, CAT, near the start of the COVID-19 pandemic, though he has been working with them to improve health for over a decade. He coordinates efforts of the CAT COVID-19 task force and provides a review of public health science and evidence-based policy recommendations to CAT executive directors and tribal leadership. Dr. Cox oversees colorectal cancer prevention, brain health, and community health representative training grants. He is founder and executive director of Integrated Research Institute, comprised of a team of applied research scientists studying, evaluating, and implementing ways to improve health and well-being among underserved minorities. He has worked as a research scientist at the University of Oklahoma. He holds a PhD in human health and biology and a master's in anthropology from the University of Oklahoma. Welcome, Dr. Cox. I think he was also having some trouble with his camera, so he may not be on camera either, but I'll go ahead and turn that over to you.
Thank you, Ms. Joseph, and thank you to Dr. Payment and all the other people that are working on brain health in tribal communities. Thank you for your work. Thank you for the support and the collaboration from Ms. Gloria Bellimil-Zuniga, who's our director from the Department of Health with the Cheyenne and Arapahoe Tribes, and also many others that have worked with us. Also, Ms. Lori Pinner from the Elder Care Program, who has helped us work and collaborate on this grant. We've also worked with our emergency medical services and our community health representatives on this grant, both in providing training to them and in them relaying information and being first line contact for many of our elders throughout our tribal area. Thank you also for the elders who have gone before us and have left us wisdom and knowledge and kindness and ways for us to walk in the good way. And we thank you, Creator, for their lives and their investment in ours today. So I again, I'm with the Cheyenne and Arapahoe Tribes, which consists of around 13,000 enrolled citizens. The Cheyenne and Arapahoe Tribes exist in an area in kind of northwest Oklahoma, which you can see on the map. The circles there are kind of the hubs of our major tribal towns from which we do outreach to our communities. And I think we can go to the next slide, please. As with most American Indian, Alaska Native tribes and entities, the Cheyenne and Arapahoe highly value our elders for their wisdom, their stories, their histories, cultural knowledge that they share. So we viewed this grant as an opportunity to enhance knowledge, improve awareness about brain health and concerns about possible indicators of a decline in brain health and cognition. Next slide, please. So we really chose to work on all three components of the brain health grant, including educating and empowering, collecting and using data to inform future practices, and strengthening the workforce. We've partnered with our emergency medical services, our community health representatives, our elder care program, and our respect programs, which are designed to be, as many of you know, kind of an intersection between our elders and our youth, and providing cultural knowledge and exercise and fun to improve overall quality of life and physical and mental health for both groups. Before this grant, the knowledge generally that our communities had about Alzheimer's disease and the dementias was limited. Certainly those who had experienced a loved one and had gone through cognitive decline and dementias or Alzheimer's disease were more knowledgeable and often are great advocates for people learning about it, but the scope of their communication is limited by the people they have contact with. So this grant allowed us to expand on that. Next slide, please. So some things that really worked well for us. You can see on the right, this is a flyer that went out advertising our annual Elders Conference, and a favorite art form, ledger art, that we have used with a number of outreach efforts. So the Elders Conference had over 250 elders that came, and it was a come and go event, and we had booths and tables set up, and we distributed information about Alzheimer's disease and dementias and cognitive health and the life course of brain health. We also reviewed a questionnaire that we developed, kind of an informational questionnaire, but also that questionnaire was adapted from a valid instrument to assess cognitive health. And so we'll talk about that a little bit. We also had display tables and provide information at our Elders Day Out that is sponsored by our Respect program. And there were over 300 elders that attended that. And one of the things I was able to do was to speak to our elders about brain health and about the life course of our brain and its health and well-being, and just some general information I was able to present to them. And we also distributed flyers and information there. Okay, next slide, please. Another thing that we did is we designed and published public service announcements to more than 8,000 community members, tribal citizens. Every household receives a copy of the Cheyenne Arapahoe Tribal Tribune. And we included some information about brain health along with our outreach to provide information about COVID, including long COVID, which we've been doing since 2020 on a regular basis. And as many of you know, there is some evidence, important evidence, that COVID can impact brain health. We see that for many, there's a loss in both gray and white matter in the brain, and some loss in memory, and in some cases, early onset of cognitive impairment and even dementias as a result of COVID and long COVID. So we've used that opportunity to help get the word out and provide information both about brain health and COVID prevention. Excuse me. We also have trained our frontline healthcare staff. More than 20 individuals from our emergency medical services team, our community health representatives, our elder care program, and our Department of Health staff have had about 3 hours of fairly intense training on brain health over the life course, and ways to assess warning signs for cognitive decline, and also the types of resources and referrals that need to be made for the elders and their family caregivers that are helping them. So those parts of the program have worked really well. Next slide, please. We were able to do some limited visits with our elders, but as many have mentioned already, and I know it's the case for many tribes, it is because of COVID surges that have happened and the risks that have come with that. We have had limited opportunity home visits with elders, but during the process, through powwows that went ahead and other events that occurred during the time frame that we had the grant, we were able to distribute more than 1,000 of these informational questionnaires to elders. An example of it is there on the right, and you can see that is actually a 2-page, so the other page is just more of the blue to red spectrum questions. But we took a valid instrument and we adapted it for use within our communities that was more understandable and relevant to different topics that we common among our people. We also asked information about COVID, whether they've been vaccinated, if they've had COVID, and things like that, as well as just other general demographic information. We also provided a scannable QR code for those elders and family members that have smartphones and are digitally sophisticated enough to do that. And with that, they were able to actually enter their answers to the questions online, which of course helps us with our data analysis and more quick response. Next slide, please. So what didn't work as expected? We had a number of somewhat unanticipated challenges for getting a mail out to all of our 2,240 elders, tribal elders, with self-addressed stamped envelopes. But we haven't given up on that. We've just been required to take a bit of a timeout, a delay. And so we look forward to actually doing that. And then our plan, hopefully when we can get to a point where COVID is not hammering us, is to actually do follow-up home visits with all of our elders that indicate from the informational questionnaires that they may be at risk of cognitive decline, so that we can provide additional information and follow up and let them know about support and services that are available to them, which was part of the systematic home visits with all of our elders, which again, we have had to pause that because of just frequent surges in COVID that have limited our ability to do outreach like that. Next slide, please. In hindsight, one of the things that worked really well that didn't anticipate, but that arose after I presented to our legislative body and our governor and chief of staff about this particular research grant, one of our tribal elders happened to let us know after that presentation that they were impacted by cognitive decline and were experiencing some challenges with it. And as a result, they came on board and really became a strong advocate for pushing for this kind of information to be given out and to be published, and included that going out from our tribal legislators to our communities. And we have found that with our PSAs with the Tribal Tribune and our Cheyenne Arapahoe TV programs, stations, our Facebook and other social media outreach, that we can get significant outreach, but there's still gaps in the people that we can reach, those that either just don't read the paper or that don't have access to computer or smartphones and don't get on social media sites and et cetera. But our legislative offices are able to reach out to a large portion of those people that aren't reached otherwise. And so through this advocacy of this elder, we were able to get more outreach through our legislative offices to our community. So that was an unexpected benefit. And so I think the next slide, I'll cover some more things. So what's ahead? We will be continuing the education of our frontline staff and our communities through PSAs and other outreach to our elders with our annual conference and our Elders Day Out that will happen every year. We are incorporating our educational questionnaire into our standard assessments, particularly for our elders, with our community health representatives and emergency medical contact with elders. We have developed, though we're still working on developing more extensively, but we've developed referrals to clinicians and social support services, including partnering with the Oklahoma State Department of Health and Oklahoma State Department of Human Services. We are still in the process of gathering data, and we will be using that ongoing data analysis to guide our future steps in efforts to inform and to prevent and to provide care for those with cognitive health issues. And in addition, with the successes that we've had and some of the efforts that are still underway, we hope to be able to apply for new grants, perhaps some from the NIH, to deepen and further extend our work and our research among our tribal populations. So I think the next slide will just be my contact information and that of our director of the Department of Health, Ms. Gloria Bellamil Zuniga. So I think she may have been able to join us on the call, but I'm not sure. Anyway, with that, I'll turn it back over to you, Ms. Carrie Joseph.
Thank you so much, Daryl, and thank you for sharing all the work you've done in this short amount of time. And thanks to all the presenters. So we have maybe a couple minutes for questions. So if you can chat those in the chat box, or chat that you want to ask a question if you want to unmute, or you can probably just unmute.
While we're waiting for that, if you can monitor for that, I wrote down a bunch of notes for observations, but we won't have time for that. But I believe that we can write them up and send them out. But the one thing that I really appreciated across the different presentations was really the reflexive and adaptive approach to bringing information to people. So Alzheimer's, different issues with memory, early detection, those are all very complicated issues. But I appreciate the adaptive approach that each respective tribal community did to convey and communicate that information to their communities, because it seems to me it's going to be much more effective if you are dialoguing with the people who are actually impacted. I especially like the reliance on the environment, the family members that are in the environment. Somebody had said that they're like a brother or sister their voice might be softer, but somehow the person was able to hear that better. And so that's, adapting your approach. I especially like the antioxidants and the omega fatty acids. Who can argue with chocolate, fish, and coffee? Yum. That's some of my favorite. But again, just that I appreciate the adaptive approach and reflexive approach of each of the communities to bring services to their respective communities.
Okay, I think we only have one question. We have a lot of great comments, so thank you folks for commenting. And let's see. One question is from George Strawley. I'm interested in the informational materials that your projects provided. Did you face challenges regarding the cultural relevance to your communities of the materials you had on hand? If so, how did you address them? Did you create materials in-house? So I know the Aleut community created materials. Cheyenne Arapahoe created some materials. Jody, I think, was creating materials. Does any of the speakers want to address facing any challenges regarding the cultural relevance of the materials you already had on hand?
This is Charlene. I'll speak to that just a little bit. So we're located, like I said, in the middle of the Bering Sea. A lot of the services that are being provided to our tribal members are coming from Anchorage, our larger geographical area. So it was really hard to get our project partners to understand, like, it's great that you have all of these services in Anchorage or elsewhere in the state of Alaska. However, we want to provide information and materials to the community members of St. Paul and what services we have locally available to them. So it took a lot of effort and I would say persuasion in order to get them to understand, like, those information and materials that we put out had to be specific to our community. So we did do them in-house.
All right, thank you. Well, in the interest of time, we're getting near the end. I just put up a screen about some resources. These are different sites. The top three are American Indian, Alaska Native focused sites where you can find information on brain health, sign up for newsletters, find out about events. And of course, CDC and the Alzheimer's Association are great resources for dementia and Alzheimer's. Administration for Community Living, the National Indian Council on Aging, the Indian Health Service, the top two being very focused on aging programs, great resource, great partners in this work. And the Indian Health Service just closed a funding announcement on July 18th. So I'm to see more involvement from IHS with the new funding they're offering. Dr. Payman, I'm going to turn it over to you to close this out.
All right. So, Carrie, I just wrapped it up, took notes across the presentations, kind of like qualitative notes. Some of it's ethnographical. And I'll send those off to you if they can be of any value. And so just to put it up back in the context that the services that tribes provide, this was heartening to hear, is that rather than just putting out services in a kind of a cold way, just the attention to the needs of the respective communities and adaptive. And you saw from different parts of the world, you saw two kind of northern territories, and then you saw an Anishinaabe community in Wisconsin, and just the cultural continuity across those communities and the way that the approach brings services to the people. That's very heartening. And so, our elders, again, are the key to our past. It's critical information that it's not only a matter of values in valuing our elders, it's also a utility factor, because they're the ones that have the information that we need, both culture, history, and who we are as people. And so thank you for respecting that and respecting your elders and the great community work that you all do. Chimigwech. turnout.